Invite the next speaker, Dr. ALOK Sati. He'll be speaking to us on PERMISLET, an innovative technique, and the discussant is Dr. Madhukar Reddy. The next speaker, Dr. Sayantan Ghosh.
Are you there?
Is he there?
Dr. Sayantan Ghosh?
A very good
Dr.
morning.
Shafina.
A very good morning to everyone. Greetings from my hospital. The topic is pterygium extended removal followed by minor ipsilateral simple limbal epithelial transplantation. That's a new term which we have coined as a PERMISLET. We have done this procedure in recurrent pterygium patients, and how the thought provoked is we got 61 years old female with recurrent pterygium and with sempliferon, and she was operated twice with excision and the conjunctival autograft elsewhere, and also she is a known patient of primary open angle glaucoma. Now, is there any answer for this? Yes, we looked into the literature because she was quite adamant that she doesn't want any further surgery, and also we should not forget that she is a patient of primary open angle glaucoma too. So we reviewed the literature and we found a technique which can offer her zero recurrence rate. And that's what came to us as a perfect technique. And we further reviewed the literature and we found that there has been just one recurrence out of 1,000 patients in a series by Dr. Hurst. And in recurrent pterygium, there was no complications. There was no recurrence. So we were quite happy with this technique and we thought of emulating this in our patient. But can we do it in our patient who is already having a primary open angle glaucoma with poor follow-up? Of course not. So we thought of modifying this perfect technique to the PERMISLET. Herein what we do, we have taken PER from perfect, that is we have done the extensive pterygium removal, but instead of placing the conjunctival autograft, because that's a large autograft has to be placed, we thought of doing the mini slit over there. So this is the surgical video for this. We often take it from the head end, though there are different ways of doing it. And you can see the severity of the sempliferon formation. So we have to release this sempliferon, and this is the subconjunctival tissue which we have to cut. And after cutting it, then we have done PER of perfect, that is the pterygium extended removal, where we have to remove the entire subfibrous tissue. Basically, we all know that the tenon is the source of further recurrence. And this is, we have to clear the medial rectus all around with the fibrous tissue, because that's what is the source of further recurrence. And that's a basic concept in the perfect technique. And we have to remove the conjunctiva, we have to remove the tenon up till the medial canthus. And once we have done that, we have done the fornicel forming suture. And once the fornix has been formed, now you can see that it's very clear medial rectus. Now we will be placing the amniotic membrane over it, followed by the mini slit procedure, where we have taken a piece of limbal tissue from superior temporal aspect. We split it into 4 and we place it at the limbus and made it adhere over there by the fibrin glue. Followed by placement of bandage contact lens. So this is what the follow-up as a day 1, day 7, 1 month and 6 month. There is no recurrence, no sempliferon, good cosmesis, no ocular restrictions, and of course our purpose is solved. We have preserved the conjunctiva for future glaucoma surgery. So we started our journey from here and landed up here. So there is no restrictions. So we have done a couple of other patients with a very beautiful outcome, I should say. So it's the evolution of the thought process which has led to this innovative procedure. And we have combined most of the pros into it, like we have done the complete and extensive removal of pathology. We have preserved the conjunctiva, We have got the anti-inflammatory effect of the amniotic membrane, and we have achieved the replacement of pathological stem cells with the normal stem cells. Though nothing can be avoided, but what's the most satisfying is that there's no recurrence, no symblepharon, and most important is that we have preserved the conjunctiva for future surgery. So take-home message is that it's a promising technique. It has the ability to change the practice pattern. And of course, we require large cohort to finally conclude our results. Thank you for your patience.
Very logical, but have you tried it for more extensive pterygium, which
Yeah,
like bilateral pterygium like that?
The pterygium which I showed in the video is, I think, it's one of the most extensive only,
Yes,
which
yes.
has involved, a
The-
lot of symblepharon and all that.
yeah.
We have what you're asking is, can we do it in the double-headed
Yes,
pterygium?
exactly.
Yes,
I'm sorry.
I have
Yeah, I
shown one
meant
of the
that. Yeah,
outcome
yeah.
where also we have done in the double.
You've done. Okay, thank you. Dr. Amit?
We get it from the Shroff Charitable Eye Hospitals. They process this under Dr. Sanwan's.
Dr. Sati, I think that's a good technique. The future, everything will move in that direction because we need to preserve the limbus as much as possible. Thank you very much, and it's
The
a wonderful
very
talk.
important thing is that we should know what is the pathology behind the recurrence.
Yes.
Most of us do not know, and it is the tenon which is, the inciting factor for it. So if we are removing it, definitely we are taking care of the future recurrence.
And we need to follow up the patients longer because 6 months is too short a time to know
Sir,
the actual recurrence.
Yeah, if we look into the literature, most of the recurrences have occurred within first 3 months. So I think logistically 6 months is adequate, sir.
Okay.
Thank you very much.
Thank you, sir.